Okay, this afternoon presentation will be a panelist session. I will start the presentation with Phaco emulsification using Diva and Conquer technique. We'll followed by Dr. Aziz Solowi. We'll talk on how we do it using a stop chop technique. Then after that, we'll continue our discussion discussing about these two methods. Okay, without further delay, I hope everybody can hear me clearly, okay? Okay. Should I go to the next? Okay, as we know, Phaco emulsification technique can be done by a lot of methods. Okay, I'm here to talk about divide and conquer method. Okay, followed by Dr. Aziz. He will touch a bit on stop and chop, which he might discuss about how to do a vertical chop and horizontal chop. Okay, on your right diagram here, you can see that the top part is divide and conquer the picture where we actually make a two trench and separated the nucleus into 4 quadrants, whereas the down picture shows that you are actually breaking the nucleus into hemi quadrant and stop and chop the nucleus. Okay, divide and conquer, first described by Dr. Gimbel, which further modified by Dr. Shepherd. They describe it as the safest, but even though it's the slowest method, but it's the safest method to begin with. Okay, a new beginner, good to start with divide and conquer method before they actually experience more on doing their cataract using a stop and chop. Okay. However, in divide and conquer method, we do have to use a higher phaco time and power because we do more of a sculpting procedure. So concentration is on the breaking or cracking part of the nucleus, where sculpting is very important. Okay, compared to phaco chop, divide and conquer is an easy technique to start with. Okay. To proceed the phaco emulsification using divide and conquer technique, we should have a good steps of hydrodissection followed by hydrodelineation. Of course, in certain types of cataracts, hydrodelineation have to be cautious, especially in a case of polar cataract. Okay, after doing these two steps, we should make sure that we have a good nucleus rotation so we can proceed further with a smooth phaco emulsification. Okay, now we're talking about hydrodissection. What do we mean by hydrodissection? So hydrodissection is actually we inflated a BSS fluid in between the anterior capsule and cortex. So these two layers is separated. Okay. So how to remember which part is which? So hydrodissection. So it's between your anterior and your cortex, DAC. Okay. Then we proceed to do. We make sure that the nucleus is rotated already. Okay, between the cortex and the capsule. Furthermore, we continue by doing our hydrodelineation. Okay, by definition, we are injecting fluid in between our nucleus and epinucleus layer. So how to make sure that you are doing it right? In some cataract that is not dense, really dense, we can appreciate a golden ring formation. So it shows that the nucleus is actually completely separated from the epinucleus itself. So with a good rotation, we are happy to proceed our phaco without any problem. Okay, then we already have a good rotation of the nucleus. We have to make sure that our endothelium is protected by some of the viscoelastic. Okay, I'm sure that early stage of the steps, we are actually injecting the viscoelastic to maintain the anterior chamber. So some of it have to be left. So in order to protect the endothelium layer. Okay, then we continue with our Phaco emulsification with a good Phacodynamics setting that has been explained by Dr. Hafiz this morning. We'll do 2 trench of sculpting which are intersecting each other. Okay, so we have a very good, nice cross before we do our nucleus cracking. So how do you want to know that this sculpting is actually good enough for us before we start cracking this nucleus into 4 quadrants? Some surgeon will do first cracking after doing the first trench and then followed by the other trench. Either way also can. So to make sure that we are at the level that we are good enough that when we do a cracking, the nucleus is cracked, is where we determine that the depth of sculpting is about 50 to 80%, depending on what types of cataract you are dealing with. So in a soft cataract, be gentle and be a bit slow because a soft cataract will get the depth even faster than the dense nucleus. Or you will make sure that your width of your Phaco tip is already 3 times inside your trench. Okay, so then you can actually see within this cross, you can see a uniform and brighter red reflex before you starting. How are you going to do this trench? Is in a method of downslope and upslope method. So you will start at one end like a bowling thing, okay? Superficial from the superior part and then going a bit more downwards, bowling out the center part of the nucleus and then going up again. So you have a very nice bowling trench of the nucleus. After you have the desirable trench, you will rotate the nucleus and do another trench to complete. Okay, so now you already have a cross. The challenge now is to separate this cross so that you have a very nice 4 quadrants of nucleus so that you can eat these pieces bit by one after another, like eating a cake. Okay, so how do you want to separate these quadrants? Okay, so you have to place both your Phaco tip and your second instrument into the bottom part of your trench. So really down and touch your floor of your trench. Then it's either you cross your instrument or you can actually press it side by side. Okay, you with experience, you will feel that you will comfortable is either doing cross instrument or side by side. Okay, so with this, you give a horizontal force. It's not a vertical force, but a horizontal force so that your nucleus can be cracked correctly. Okay, so that you didn't endanger your zonules. So from the diagram down here, you can see that the correct way is to bring both your problem with my arrows. Okay, both your from the diagram, both your Phaco tip and your chopper at the bottom of your trench. Whereas on your right side, when you put your Phaco tip and your chopper at the level of the superficial trench, you are not able to crack it fully until your floor. Okay? Okay. Then you will switch your Phaco setting to a cordon removal setting. then we will eat your quadrant one by one. Okay, it's good to engage your nucleus first rather than um, um maintain in the center and then help depending on the vacuum to suck out the nucleus itself. It means that you have to go and kiss one of the piece of the nucleus, bring it more towards the middle of the pupil and start emulsifying the piece one by one. So it's good to do your quadrant removal at the level of iris plane to reduce your uh, risk to touch your posterior capsule and to reduce the risk to give burn to your endothelial layer. Okay, what is the good Phaco setting in divide and conquer? So for sculpting, usually the vacuum have to be low because the main thing is for you to make sure your nucleus is in the back so that you can have a very good sculpting. Okay, aspiration is around 15 to 20 cc per minute. No need to be so high, but if you have, sometimes you will have busy AC. Busy AC, why my AC is so busy, it's so cloudy, you can increase your aspiration a bit so that all the cortical materials is sucked faster. So Phaco setting for sculpting is enough between 40 to 50%. Okay, you don't need it to be so high unless you are dealing with very hard Brunnerson cataract. And the teeth have to be 50% occluded using a continuous Phaco. Okay, in sculpting for divide and conquer, you have to do a continuous Phaco. Burst and pulse is not a setting for sculpting in divide and conquer method. Okay, after already you doing a very good sculpting, the setting for emulsification of the lens is a bit different. This is when you want to take out your pieces and eat it one by one. So your vacuum has to be high because you want to engage it and hold the nucleus. Okay, so your vacuum have to be at a reading of 250 or 350 millimeter mercury. Your aspiration rate increase a bit to 20 to 25 millimeter mercury. Power still depends on the lens density. Okay, in a low set, in a immature cataract or soft cataract, you have to lower your power a bit because they will be eating so fast. Okay, this immature cataract. So 70 will be too high for the soft cataract. Will end up with endothelial striation. So you can go down to 50 to 60 for your immature cataract and go up to 70 to 80 for your very dense nucleus. Okay, certain machine they have an IP setting which actually will go according to the density of the nucleus. So, and in emulsifying stage, your tip have to be full occluded. As I said just now, hold the nucleus and the tip have to be fully occluded, then it will eat nicely. Okay, and in this stage where you can decide to use either your continuous, your burst or your pulse setting, which your burst and pulse setting will give more advantage to your endothelium because you are using less power. Okay. Okay, we already go to the hardest part of divide and conquer. So we are happy already, but happy not to be so happy. Okay, we go to the aspiration and irrigation and aspiration stage. So this is still an important step to be given an attention because if we do the irrigation as an aspiration without big attention on our posterior capsule and the anterior capsule itself, you might end up with complication. So partly when you introduce your pot or your IA pot, your IA probe, you have to make sure that the port is always upwards and always under your visualization, because we don't want this port to cause the unnecessary structure in the anterior chamber. Okay, the task is a bit more difficult if you have a written epinucleus. Okay, so you have to make sure that this epinucleus is fully rotated also before you embark to do your irrigation and aspiration. How to make sure that this epinucleus is already loosened, so you can actually do another step, do a manual irrigation with your BSS. Okay, then you proceed with your automated IA. You can use either coaxial IA or manual IA. For your irrigation and aspiration. Okay, what is coaxial IA? Coaxial IA means that you use only one probe, where the probe actually have both your irrigation and aspiration port at the same time. Whereas bimanual IA is you have a separate probe for your irrigation and separate probe for your aspiration. But in this case, you have to have another wound for that. Okay. Whereas for manual IA, your manual IA is your simple IA as you use for your procedure of extracapsular cataract extraction. So some beginners will complete their Phaco emulsification until the emulsifying stage. When it comes to irrigation and aspiration, they will start first with manual IA to get their confidence. Later on, they will switch to the automated IA. You are using your Simco at that particular time. Okay. So some beginners also will ask for continuous irrigation. Okay. So at first, we will actually, it's good to have a continuous irrigation, but time to time you have to upgrade yourself, because continuous irrigation is not all the time good to your endothelium, because it's continuous risk to damage your endothelial cells. Okay. As for bimanual IA, the good of it is actually you have an easy access to your residual cortex, especially that hidden at your level of your subincisional area. Okay, just behind your main wound. So this is tackled easily by doing your manual IA. Okay, when you already have a very good cortical matter removal, it's a time for you to implant your intraocular lens. So these steps will actually same with other method. After you complete your Diva and Conquer, your IA, your IOL implantation, wound closure are actually all the same steps in all of Phaco emulsification technique. Okay, so you either will be given a manual IOL to be implanted, or you already have a preloaded IOL to be implanted. Nowadays, everybody actually prefer to have a preloaded IOL because the handling is actually more easy, is easier compared to the manual implantation of the lens. Okay. Then followed by viscoelastic removal. Can we leave viscoelastic in our eye? Of course cannot, okay? Because viscoelastic is just a temporary substance that actually we use to maintain the anterior chamber of the eye to facilitate our phacoemulsification. Later at the end of the surgery, we have to remove this viscoelastic after we remove the cortical matter, okay? So we have to know what type of viscoelastic that have been used. Okay, whether it's a visco-cohesive type or visco-dispersive type. So we actually under microscope, you actually can appreciate the clumps of viscoelastic inside the bag itself. So you may visually can actually appreciate when you suck up this viscoelastic during viscoelastic removal. So some will still be stickily attached to your IOL. So you can do a quick and fast irrigation of this viscoelastic with your BSS at the main wound. But be careful not to really go deep into the back. You might touch your posterior capsule. So the aim of removing the viscoelastic is when you see a horizontal striation of your posterior capsule. It means that, oh, I fully remove enough my viscoelastic. But you really have to make sure that there's really a striation of the posterior capsule, but not a PC rand. Okay, so it'll come to you with times and experience. Okay, so in other way, you can actually digitally touch your cornea to just gauge whether my IOP now already normalized or not. If the viscoelastic is still a lot in the back, your eye still will be still hard. Okay. Okay. Last but not least, you have to close your wound. Okay. So wound closure is very important, and it depends on how good you do your wound construction. If your wound construction is good, you have no problem doing your wound closure. Okay, but if you have a very poor wound construction, there will be a problem where you start to hydrate your wound a few times. Suggested that if you already hydrate your stroma more than 3 times, don't further inject the stroma, just ask for suture to be used. Okay. Because there is one because of poor wound construction, but sometimes when you want to implant your lens, you have a lens that actually the cartridge is big than compared to other lenses that to be implanted. So you have to wound a bit. So be careful when you want to enlarging your main wound, you are actually at the same plane of the wound that you have been created before. So because if not, you will unsuccessfully close your wound with your simple hydration. At that particular time, you still need a suture to save your wound. Okay, don't hesitate to use a suture because this is an important stage that you have to decide, because leaking post-operatively, if not managed properly, you will end up with a very devastating infection that nobody wants it to happen. Okay, so ask for suture. It's not an embarrassing thing to ask for suture if you cannot close your main wound. Okay. Then lastly, paracentesis wound. Do you want to hydrate or not? Okay. You want to hydrate. Why you want to hydrate? Because it's still leaking. Why still leaking? Still is go back to a wound construction. If you have a very good paracentesis wound construction, closure is not a problem. Okay. If still you hydrate a few times, not more than 3 times, if still leaking, AC still collapsing, your lens started to come out from your back, better to put one suture. Okay, and on the other hand, myosing the pupil will help your iris diaphragm to maintain your lens in the back, and this will help in your wound closure also. Okay, I think that's all for Divide and Conquer method. I will end up my presentation for Divide and Conquer with a short video from courtesy of Dr. Susan. I actually extract it from YouTube. I hope you can actually enjoy the video.
Dr. Zairah, thank you for a very comprehensive teaching on Divide and Conquer. But can you please stay there? After the video, can you please stay there, Dr. Zairah?
Just click here then.
Thank you for a very comprehensive presentation. Maybe you would like to share with the participants about the length of the groove, the length of the trench. Is it important, the length of the trench?
Okay, the length of the trench still depends to the density of your cataract also. If you are dealing with the soft cataract, okay, the length should be at the tips of your end of your CCC. Okay, up to that level, you are able to crack your nucleus already. But in a dense cataract, if you're able to go a bit more further, half of your um, visualized residual CCC tag, then it's good because along the things that a bit longer in a denser cataract will help in terms of cracking. But people will talk more of depth rather than length. So still to me, the depth is actually it matters more. So whether your cracking is successful or not still depends on your depth.
Yes, yes. Thank you. Because I think there's no need to actually to groove until, you know,
Yeah, until you
the
cannot
very end
see
of the, yes.
equator.
Because it's kind of dangerous, right?
Yes, you will accidentally catch your anterior capsule itself,
Yes.
and at the end, your thickness of your lens is not as at the center part of the nucleus. You might over sculpting and catch your PC at the end of the peripheral equator of the lens.
Yes, I think that's very important because I can see some of the trainees they love to grow quite a long trench, you know,
Uh,
up to the equator. That then we think that it's actually very dangerous.
it
Then
can be done if you are already good in your techniques and skills, and you are very confident of doing it, but not recommended for a beginner.
maybe we can go back to your slides to the setting of sculpting and quadrant removal. Participant to actually compare the vacuum, the power, and not forgetting the aspiration flow rate. Yeah. Okay. How does that aspiration flow rate actually help in that two setting, in that two procedures?
So in a setting of sculpting, we actually want to make sure that uh, the aspiration is good enough to uh, to aspirate the surrounding particle matter that actually been emulsified. So do have so that we have a clearer view on what we are going to sculpt. Okay. Whereas in emulsifying stage, this aspiration is important. That's why we aim a bit higher because you want the piece to come forward more faster and eat more faster so that we have less heat from the Phaco probe itself. But the difference is not so much actually. It still depends on how cloudy your anterior chamber during your sculpting. Sometimes we will actually on and off adjusting the aspiration rate during the procedure.
Okay. Regarding cracking, is there any, I mean, suitable distance from your main wound to your side port so that it can actually aid in cracking the nucleus?
The the the
The distance between the main wound and
and the
the side port,
oh
so that
okay
it can
okay
easily crack the nucleus.
Yeah, okay. So when do you want where do you want to place your paracentesis wound and where do you want to place your main wound is actually very important. Okay, I miss up that in the explanation. So it's good to have a distance of more than 90 degrees to each other so that you have a very good distance to manipulate these two instruments within the eye. Okay, if you actually place these two wound less than 90 degree, you have difficulty to crack it, and you are actually at a stage of what we call an R situation where you cannot actually go further to crack the nucleus. So to start with, you can go more than 90 degree and adjust a bit more at your comfortable side. Okay, any other questions before I pass my mic to Dr. Aziz?
Yeah, any doubts from the participants? Because it's actually quite hard to find someone who actually does an original Diva and Conquer. It's so hard for me to find a surgeon with an original Diva and Conquer actually. Yeah.
Yeah, doing Phaco and chop nowadays. Only
Yes, yes.
only a
Most of the
citizen like
surgeons
me
has
doing
converted
divide and conquer.
to chop, but it is a very good start for beginners to know how to learn this Diva and Conquer correctly and properly. Actually, it all starts from this, our skills actually starts from this Diva and Conquer. Okay, we have question, Dr. Zairah.
Okay, repeat the part about how the angle should be cut across half the thickness of this morning. That one I will explain tomorrow, I think. Okay, in soft cataract, sometimes it's very difficult to crack the nucleus. In and up, no more nucleus in the center to give traction of the track. Any advice? Okay, not all soft nucleus are good when we are actually doing our divide and conquer technique. So we have to modify a bit the technique of doing this divide and conquer method in a soft cataract. So the key word is actually hydro dissect and hydro delineate properly your soft nucleus. So you have a very good lens rotation, because when you start doing your first sculpting, gently, not to actually destroying your good trench, is actually good enough. A first trench in a soft cataract that actually deep enough is good to crack, and when we already have these two hemisphere quadrant in a soft cataract, actually, believe me, it's quite easy for you to go to your quadrant removal setting already. Because in a soft cataract, you have more problem dealing with epinucleus rather than nucleus itself. So you can engaging this nucleus by just doing one cracking when you finish with your good first trench. Okay?
And another thing, when I observe my trainees doing this divide and conquer, they want to, usually the problem starts in cracking. They have difficulty cracking. I think everyone will agree with me. No, when then it's actually, they will actually press the wound. It's not the wrist movement, it's actually the elbow movement.
Yeah. Because, okay, to master your cracking, you have to practice at home. Put your two hands inside your tin biscuit. Okay, you're going into a small hole. So, but only your hand, your joint of your hand is moved, not your elbow is moving. You have to keep your armpit very close to your body and only move your hands. This is what Dr. Azura always said. Practice pivoting, and pivoting. Okay? pivoting means your ability to move your hand joints, your finger joints inside a small compartment. Go at home and try to put your hand inside a thin biscuit. If you're able to do that without using your elbow and your shoulder, you will be good at your phaco emulsification cracking technique.
Yes, that's
Okay?
yes. Pivoting is the word. Okay.
Okay, what are the precautions during hydrodissection to prevent PCR? Okay, question might be overlap over today and tomorrow because maybe we'll talk about the same thing. Okay, since the question is already up, so the precaution of hydrodissection is before you decide to do your hydrodissection, you have to know first what type of cataract that you're dealing with. Okay, make sure this is not a polar cataract. Okay, then for a normal cataract, what you have to do, if an immature cataract is a bit easy, so because you can visualize your wave, so do a gentle small volume of injecting your BSS in a few clock hours and press down the nucleus a bit so to make sure that the remaining fluid at the behind your nucleus in the back is actually forced out. So with this, you can actually prevent your posterior capsule rupture. So don't do a harsh hydrodissection at one time to begin with. Okay, but I've seen a surgeon doing that because they already know how much to inject and the force to inject. Okay, it's okay to hydrodissect a few times, but not so multiples because multiple injection also will endanger your posterior capsule. Okay, am I answering the questions? Okay, we go to the next one. Can we still proceed with Diva and Conquer if we are not unable to rotate the nucleus? Okay, I'm a achy person actually. Okay, so if in my hand, if my Diva and Conquer in a very dense cataract cannot be done, I usually convert. But many surgeons actually will try to make sure that the lens can be rotated. If you already do your Diva and Conquer at first stage, if you want to rotate and you cannot rotate, it means that your hydrodelineation and hydrodissection is not enough. You can actually go out and do a bit more of hydrodissection and hydrodelineation and try to make sure again that your nucleus can be rotated, and from there you can proceed. Okay? I'm sure once your nucleus can be rotated, you can proceed. Unless there's something else happening, you already did your hydrodissection a few times, it still cannot rotate, you have to think of something else happen. Okay? Go out and then reassess back the condition. Whether your pupil has been snapping, your AC become more deeper, and then anticipate complication. Any more questions?
Shall we start? All right, this is Phacotechnique. I'm presenting to you financial disclosure. So this is a high-end chopping line, I suppose. This is I'm using Centurion with Active Sentry. Active Sentry is where the indicator or sensor is at the Phaco tip or Phaco handpiece, not the cassette. So you see a very high very high volume, high vacuum surgery. So I just start. So this is my wound. Once in a while, I will just forward this just to save time. So 2.75 wound, I hold my wound like that, stabilize the eye. I use 2.75. This is OBD. CCC. My tip of looking at cataract video, you just don't look at the video only, you look at the parameters as well. You look at the power, this is the torsional, longitudinal, the amount of fluid, this is a foot pedal. Okay. All right, complete the CCC. This is hydro dissection. Complete hydro dissection. I will start with small groove, small but very deep groove. How deep is the groove depends on the nucleus. The thicker the nucleus, the deeper the groove should be. So this is, it is not like divide conquer where you can actually, you need to see probably reflex inside deep groove. In divide, in chopping, you don't need to groove too deep, as much as is sufficient to just hold the nucleus. So I clean up the cortex so that I can see the nucleus better. I rotate using Sinski, and I hold. I turn to chop setting. I rotate again. Okay. Any idea how to this one? Yeah, because I need to see the parameters. Okay, yeah, thanks. All right, using high vacuum. This vacuum is up to 600 over. Your normal vacuum would be about 400. So using active sentry, you can actually increase up to 700. Okay? So as you can see, vacuum high, I apply a bit of torsional, then I chop. But you have to make sure you chop until you can see the PC. Okay? Completely detach the segments. See, detach the segment from at the base. So you do multiple chops. High vacuum, chop into multiple slices. And as you can notice, right, I don't go to periphery at all. I use Sinski, everything happens at the center. I hardly even go beyond the CCC edge. So look at this. Okay, I tried to remove this segment. So just to demonstrate to you, big segment. So the active sentry activated. So okay, this another segment. I took it out. Once pressed, it's all gone. Another one. You take it out, it collapses onto you. You use the shaft of the Sinski, and it's gone. So this is the way we reduce the Phaco power used in any surgery. So this is another one. I use the Sinski shaft. I chop it into smaller pieces. I press foot pedal. Few seconds is gone. And try to rotate. I insist my trainee that they must rotate towards the opposite so that they can chop better. So hold, using high vacuum, apply a bit of torsioner, then chop. Torsioner is the Phaco, torsioner Phaco in Centurion. Okay, it is very safe. All right, finish with Phaco. So what I normally do with IA, I start with subincisional cortex first. There are many reasons why people start from superior for subincisional. Sometimes for trainees, right, when they struggle with the wound, they will hydrate the stroma. And in the end, when they leave the stroma, I mean the subincisional to the last, in the end, they will not be able to see it because it's stroma hydrate already. So by removing it early, I think we will settle it first, right? So before we, before we remove the rest. Old school of thought will say, why are you removing it first? Because if you have your PC run, it will be very difficult to remove the rest. So it depends on the way you look at it. So I also polish the CCCH. Some people don't do that, but I'm still doing it to clean it up. Right? This is the CCCH. And I will check the second port wound just in case any cortex or any epinucleus left at the second port wound. So OBD, you must check the PC first before you inject IOL. So look at how the haptic comes out and arrange it or rotate it accordingly. Removal, so I will start with second port stroma hydration first. Form the AC, close the inner lip of the main wound. So sorry for that Shopee thing. All right. Okay, no leaking. So done. Shall we proceed with question first? Because just to fill up time, I have some other videos to show. But I think to be fair with the first presenter, I think I will open up to question first before I proceed with other videos.
Yes, thank you, Dr. Aziz. Because Dr.
sharing.
Aziz has converted me to complete multiple chop Phaco. All right. I just want to because you are not cracking, right? Maybe you want to share that your wound distance might be different from divide and conquer. The distance of the main wound and the side port should be different, right?
Oh, okay, all right. It depends. The distance from my main wound and the second port is about 45. Sorry, about 90 degrees. Because I will not be able to do, for example, if I do temporal, my distance of wound about 45, I will not be able to do that horizontal slicing because I need that degree, I need that distance, or actually 90 degrees, so that I can effectively slice with the shaft of the Sinski. Otherwise, I will not be able to do that. So for divide conquer, I think they can do temporal, the distance will be smaller. So there's a difference.
I cannot do 45. That's because I think it's too close.
Yes.
But what I do, I will do. I can't do 90 either. So I think it's very far for me. It's very hard to rotate. So I will do around 60.
50, again, 50?
In the same method of yours, I will do around 60.
60, yeah, correct. You need a distance. for you to effectively chop horizontal. The vertical, the vertical chop, the initial part, that one is possible if the distance is short, but the horizontal slicing it's not too good if you do too far away.
Okay. What about the chopper then? Is it what is the difference if using Sinski or using the longer chopper like Nagahara or even using a sharp tip chopper? What would you suggest then?
Right. The reason why we developed this technique initially because Sinski is in every set, in any set and available anywhere, easily available in any set. So that's the reason. And I want to standardize the technique or the availability of the chopper, chopping instrument. And the other reason is because it is short, it's blunt, and it's very safe. And as you can see, I have made that into my primary instrument instead of Phaco, instead of moving Phaco all over the place, which is is very dangerous. I actually move my Sinski everywhere. I can actually dance around using tips of the Sinski. I can capture anything. I can use anything with Sinski. And it's safe, it's soft. I mean, it's blunt. And actually, when you have hard cataracts, if you are not okay with Sinski, there's a thing called sharp Sinski. You can actually make it sharp. It's available in the market. But it's short, it's sharp. But quickly, once you have done your vertical chop, you have vertical chop for hard cataract, you change it back to blunt Sinski. It's safe, I can tell you. It's cheap, it's safe, it's magic.
Okay, so because you need actually the vacuum is more rather than the power itself, right?
Yes.
So what are the type of tips of Phaco tips that you would suggest for those who want to actually try to learn this technique?
All right. As what I've been teaching the trainees, the most important thing about Phaco chop technique is not the chop, is the holding. So people misunderstood this. So they are to concentrate too much on chopping. When they hold the segment, they want to quickly chop. This is Phaco chop technique is about holding. So meaning you're holding with high vacuum. So that's why the active century you can actually go up to 700 vacuum and holding with a good pedal control. You don't eat it up. You just hold vacuum. You apply a bit of Phaco power or torsional, then you go back to your vacuum and hold it. So the key about doing Phaco chop is holding. So when you actually hold, you can do anything with the segment. So you can chop using sharp instrument or blunt instrument, doesn't matter. And the other key is to hold it and to rotate to lateral, rotate inside the bag, so that you can actually open it up, open the fibers up to the base of the nucleus, and you open it up. So failure of chopping is about not holding properly and not rotating it properly and not separating it up to the base. Were you asking about instrument? That's all?
The tips.
Yeah, you shouldn't be chopping using, there's such thing as chopper, it's long, but at the tip there's a mushroom chopper. I don't know what you call it. This is round. You shouldn't be chopping using that in vertical chop, okay? Because it's round. Theoretically, it shouldn't be used in vertical chop. It can be used in horizontal chop. But when you notice, when you actively move in AC, you will think about Sinski. You will not be moving your chopper, long Nagahara chopper, so actively in AC. Okay? So you'll be, try Sinski. You can actually move it much better and safer than other chopper.
How about the Phaco tip then? Do you
You're asking about Phaco tip?
Straight tip or Kalman or even balance tip?
Okay, that depends on surgeon. Any surgeon can do any tip. Kalman, the one with the bend tip, is actually good. it's a good tip. I think Calman, if you are choose, I'll choose Calman, but that doesn't mean you are not okay with others. So now I'm trying to explore the possibility of using a small 2.2 gauge with Signature Pro or the normal Phaco with normal sleeve, and to try to make slices or vertical slices to make Phaco easier. So we are exploring this method.
You mean very small, you mean really multiple chop of the
Yes.
nucleus, and then you just, you know, like vacuum the
Yes, some videos available, but not sure whether it's available to show. The idea is about holding small pieces, higher vacuum, to make slices. If you imagine cakes, a piece of cakes, right? When you bake cake, you want to slice it into small vertical pieces. Then after that, things will be effortless. So once you start removing the cement will just jump into your Phaco Pro, and your Phaco power will be so much less.
Since your groove is actually small and short, and do you have, I mean, how do you see the reflex then to know whether it's actually deep enough?
I never assess it through the reflex. I assess through the depth. Let's say if I have dense cataract, old patient come to me, dense cataract brunescent, I will probably do chopping halfway through grooving. I will just stop and assess visibly. I will assess, or I will look into the depth. I don't look for the reflex. So if I think that I have reached half of the nucleus, I can actually hold for chopping, I'll just proceed. And you don't need to go too deep for chopping. You can, as long as you can hold the nucleus, holding high vacuum, good pedal control, you chop, and that's it.
So for the setting, right, Dr. Aziz, any difference of setting in different machine?
Yeah, setting is for different brand of machines, I suppose. It depends on the machine, it depends on the type of cataracts, I mean, machine that you have, whether it's Venturi or peristaltic. But I don't see much of difference. Nazrah, it's a matter of types, Venturi or peristalsis. And I noticed actually not much of difference. I think it depends. I normally use the default setting for the machine. Then what I do with the machine, I call rep to optimize it for my setting. But I normally do high setting, high vacuum setting. High vacuum, especially with the small groove, the small probe, right? I use very high vacuum. I increase to 450. Like Active Sentry, you can increase up to 700, but that one is peristalsis as well. But for Stellaris Elite, I will optimize it to the fastest response, very high vacuum. There are many other small little like your setting that you can actually. No, for beginners, I think even for the surgeons, I would say not to worry too much about your setting. It comes to the default setting. If you need to call the vendor to stand by with you to optimize it, by all means, you call them up and save your setting. Then your setting is for yourself. I rarely change my setting for any type of case. It's all the same. They're all the same. It's all about your movement of your hands, the way you chop, the way you put your pedal down is more important.
Since it's more of a movement of the second instrument, do you reckon this for left-handed trainees?
I'm a right-handed person. So when it becomes to Phaco, my left hand move more active than my right hand. So I'm supposed those left-handed surgeon can combine, but I've trained some of them. They follow my style. Left hand becomes active, but not sure, Nazrah, whether they actually because they move it better because they're left-handed. Because right-handed person also can move that left hand quite okay. You just need to train yourself.
Yeah. I think Phaco is all about the integration of your right and left brain, your right and left foot, your right and left hand.
Yes.
Okay. Any other question from participants? I think for chopping might be they might have to digest more. I think, yeah. Most of them are what do you call, learning on divide and conquer first, yeah.
Oh, can I answer this question, anonymous? Does making wound at the steepest cornea region really help with reduction of stick post? Oh, yes. Can they hear me? Yeah. Yes, it is. But for the reason for me, I would prefer doing superior. I don't have issue with my astigmatism because I don't move my wound at all. I don't move my wound. I don't inside in out too frequent. I go in once, I go out once. I don't hydrate my wound. So my astig is kept low. Unless it's high at the steepest region, I'll probably consider doing it there. It is, yes, you should be doing at the steepest corner region. But for me, I have my personal reason why I do standard superior. But you all should be doing at steepest corner region, yes. This is for this blurry station this morning, right? Angle should cut across half the cornea. Okay, this is what, which question should I answer? Is there a need for surgeon to learn to implant toric lens? You should. Yeah, you should. You should learn how to implant. You should learn how to do the measurement. But more important to learn the basic one, the basic Phaco. This toric lens, it comes with its own requirements, its own set of what you should, what have you achieved the certain level, then only you will embark on this. This is another journey. So make sure you do your Phaco basic, very basic first, before you start another journey. This is a totally different journey. Implanting toric is easy. It's about the measurement. It's about the outcome, which is more important than surgery. Surgery, anybody can do that.
Any other questions from the participants? Are they still with us? Are you still with us?
Yes.
Nazrah, if you have time, we still have time, no question. I can actually show some videos.
Yes, please, Dr. Aziz.
Just to fill up time.
Yes.
But shall we wait for some questions first, or?
Oh, they can actually type. Maybe
Okay,
in
the chat, right?
yeah.
Okay, I share my screen again. Okay, I continue with the share screen. Okay, I share my screen again. This is about this morning. I promised to show some videos. This one. Okay, next one. Okay. All right. This I can't remember which one. Right. I just put it up there. See what happens. So this is a patient. Okay. Dense intumescent. Okay, I remember this already. So look at the CCC. This is done by one of my trainees. So this is after vision blue. Sorry. I just forward a bit. This is an old video. I think it was done in 2016. So when you do CCC, the direction of the pull should be to the center all the time. Center means radial to the center. So this is what happened when it's not at the center. And then you press your wound, okay? Then it stops there. Okay. Right. So it's very important to have a teacher who can bail you out, okay? Okay, this is, so you take over. So this is to answer the question about this morning, whether it's possible to proceed when the CC is extended. So you don't do this alone. If you are a beginner, I advise not to do this. You seek help, SOS, or your consultant come over. Because for me, I would prefer to do this rather than to do ECCE. Some people will just convert this into ECCE, safer. It is safer. Eh? But it is possible with this chopping technique, it is actually possible to proceed with your Phaco. Because I believe that many people, many surgeons will probably not agree with me. When I do ECC to save this, I will do more, I'll probably deliver the nucleus together, the vitreous together with me, together with the nucleus. So it becomes messy. So why not try to just complete? So you salvage CCC and just to try to complete. If can't complete, okay, fail to converge. Yeah? Continue. Chop. Eh? All right, small groove. I will show you another better resolution video tomorrow. Another case. It's the same one. We save surgery with the extended CCC. So it's the same. You rotate. If your audience have questions to Zairah or me, you can just keep it all right somewhere. We will answer. We will stop after one video and answer your questions. So you chop. You hold nicely and chop. Tomorrow there'll be another better video. Okay, until you get that line. Okay, and just forward. Okay. So the segment sort of floats. So it doesn't compromise the, again, sorry. Chop. So bear in mind, this is in the presence of extended CCC. So you chop. This is what we call, what I call horizontal slicing, using the shaft of the nucleus. Chop. Okay, so PC is still there, right? So I start with the subincisional cortex. I'll try to avoid the place where it is extended, 5 o'clock. This is to insert IOL. Okay, it's done. Okay. IOL stable. No extension of the CCC. So it is possible, but in good hands. You don't just learn Phaco and when you have extended CCC, you want to try this. There's no such thing as that. Try to think about your question. This is another one to answer the question earlier, capsular fibrosis. Probably this is the only time where I use bend needle, other than the other to salvage the CCC. So I specifically use bend needle for this. I don't use Utrata. So when it come out, you inject OPD. So it takes time, just forward. So this is the way to do it. You have to be patient. You pull. You have to get rid of the capsule, the capsule fibrosis. Okay, it comes out in pieces. You have to continue. You have to do another one, opposite direction. So I needed to create another tear. Okay, the multiple tear. Some people like to use Vana to just cut this. So the possibility of this to extend is probably minimum because it's already fibrosis in the first place. So not to worry. So until it's complete. So bear in mind, doing Phaco in this type of cataracts, they will normally have zonolysis. They will have zonular weakness. It comes with this hypermature cataract process. So the same thing, I use Sinski. So holding is very important. So this is not using normal Centurion setup, about 450 vacuum. So you see how my Sinski works. So you actually rotate, you don't pull it towards, you don't actually pull towards opposite side, you actually rotate inside the back. The movement is rotation. Yeah, rotate until you reach the base. So it's the same thing. Hold, high vacuum, a bit of torsioner. It's rotation, it's not pulling, it's rotational movement. So you remove one by one, you are safe already. It's the same thing. So put it opposite, hold meaning you apply vacuum, you rotate the left hand, the left Sinski. So using shaft, you try to horizontally slice it. So you hardly touch the capsule, right? So the capsule will not extend. Okay, done. Shall we, anybody want to ask question? Anyway?
There is some question.
Ada soalan, ya, how to stop this? Stop sharing, Stop sharing. Tekan mana? Ada soalan kot, stop sharing. Question, any question?
Any questions from the participant?
Oh, banyak. What is this? Can we start somewhere? Okay. Apart from the obvious rand mark, how else do we detect that there is a high chance that PC rand has occurred? Zairah nak jawab? Zairah can on. This is a subtle sign. Sometimes when you look at how your segment move, or when there is what we call papillary snap sign. Papillary snap sign meaning this fluid suddenly goes behind. Suddenly there's an opening behind. So people become small suddenly. That's a very subtle sign. And I also have videos and I can't accommodate all the videos in. I have that papillary snap sign. And the other thing is PCRN. And your segment doesn't move as usual because of vitreous come out, or you can remove, or you can Phaco, you can do segment removal using Phaco because there's a vitreous there. Yeah? And those are the, but you have to detect the subtle signs first before you detect PCRAN, before you can see PCRAN. So it's about detection, or PCRAN is about preventing PCRAN. It's not about doing surgery, everything, then looking for PCRAN. It's about your technique. You have to prevent. So in this Phaco, what I showed to you, everything happens at central. Everything happens at the surface zone inside the eye. So chopping everything inside there. I don't chop beyond the CCC. I don't even chop beyond the iris. So everything is chopped at the center. So everything happens at the center. This is about preventing PCR. Zairah nak jawab?
Yeah, apart from what the factors that Dr. Aziz already mentioned, very snap, and then suddenly your anterior chamber become a bit more deeper than before. Then difficulty in rotating, as Dr. Aziz mentioned also just now. So when you try to chase your quadrant, you cannot catch. You cannot catch your quadrant. Instead of catching it, you are actually make it fall more backwards, and you can see that you have difficulty in engaging this piece because there already a strand of vitreous blocking your tips of your Phaco probe. That is actually the imminent signs where you should go out and then reassess back the condition. So you have to know that a few tips of detecting or PCRAN. To start doing and managing your PCRAN accordingly.
Okay, does it answer the question? Yani superior approach, some surgeons prefer wound over 90 degrees, immediate superior, while some prefer supranasal temporal. Are there any other than preferences? This is for superior, right? I can't think of anything other than supranasal, supero-temporal, and temporal. Temporal should be that approach, kan? Anything else? I don't think so.
That's all. Superior, supranasal, and temporal. Supranasal is a bit difficult because you have your nose there.
I would like just to mention here, right? When somebody said, "Oh, my approach is temporal," the approach is not because the surgeons want some space to sit or some space to approach the eye. It's about temporal. It's about really temporal wound. So some misunderstood that temporal means sitting temporal.
No.
About doing wound temporal. It's not the surgeon sitting temporal. Yeah, the one you have to understand. You have to correct the misunderstanding, because I've seen some surgeons sitting temporal, but the wound is actually superior temporal or supranasal, kan? Supratemporal.
So, jadi inferior nasal. Your makeup. And other
Inferior
side.
nasal, correct.
Your right eye and your left eye will be superior.
You're talking about the wound. You're not talking about where you sit. Eh? You have to understand that.
The main thing you sit temporal because you want to introduce your main wound actually at 180 degrees to combat your astigmatism that exists. If not, everybody will happily sit superiorly.
All right. Any tips to inject IOL in a small 2.4 main wound? Well, 2.4. 2.4. You can dock like single piece, like IQ and all those. You can actually dock it, no issue. The one that you can dock is the 3-piece, but I think 2.4 you can dock, right? Nazrah, can? If it's with single, you can actually dock it.
Even 2.4, 2.75,
You can dock it.
method that you have to learn. Okay, it's the learning of curve because some lens, this we still need docking while using 2.75 main wood.
Yeah.
But you have really to make sure your eye is stable because when docking, there's a possibility that injecting the lens outside the eye once your patient is moving. So, so working with learning good learning curve, you are able to do it. Tips for 2.4 is still the same with 2.75, but there your cartridge have to be smaller for 2.4. If not, docking won't help.
Yeah, I have to agree with Dr. Zairah, I think, because docking, even me, I still have I'm quite afraid of actually docking. It depends on the type of lens actually, because it can, when patient can just move and then the lens can just come out to the eye, not into the eye. So I think it's quite dangerous for trainees to try to dock. Better to actually make sure that the tip of the cartridge really is really into the inside the AC. But having said that, some manufacturer actually claim that they can actually enter the even the 2.75, they can actually enter 2.2 wound, but when actually we really have to dock, right? And some of my cornea team friends would suggest to actually extend a bit the wound.
Talking about the wound size and 2.4 wound, it depends on surgeon's preferences. But personally, I believe 2.4, 2.75 is all about, there's no point having 2.4 wound when you drag your wound, when you manipulate your wound so much, because your ST will be high.
Yes.
Compared to when you have 2.75, you have a free movement, you don't create corneal striae, you don't damage your wound. Probably when you compare doing 2.75 and 2.4, when you take care of your wound during Phaco, probably your aesthetic will be better in 2.75. That's probably my belief. So I end up, because I'm been teaching students, I don't teach them 2.4. I've been using 2.75 because I want them to have a feel of doing CCC. Or probably when they graduate later, they want to change to 2.4, 2.4. No issue. But they need to understand that having small wound is no point when you are messing up with your wound. That's the idea.
Yes, and then they have to know, they have to know all the instruments that is actually suitable. I mean, let's say if they do they make 2.2 wound, the capsulosis forceps, the sleeve has to fit in. The tip of the cartridge has to fit in. Otherwise, it doesn't serve the purpose.
How to do hydro delineation? Well, my way of doing, I would do groove first. I'll groove, I don't rotate. I'll groove, I will hydro delineate from inside the groove. I will inject BSS from inside the groove, then I can see the ring. That's the way I do polar. Zairah?
The same thing. We have
Okay.
polar, we groove a bit, and then we go in between the grooving.
Yes, in that way you can see, it's visible inside the groove. You actually know which layer to hydrate. So that's safer than just doing bluntly.
Usually we will do hydro delineate first in polar or pseudo polar. If not, better in normal cataract, is good to start with hydro dissection. Then you can have a good hydro delineation after that. So to start with hydro delineation first, a bit of grooving will help you to have a good delineation.
Right. I think that answers the question. Okay. In the case of extended CCC, is there a need to rotate our haptics, position them away from the area of extension? Advisable. I think they should do that. What do you think, Zairah? I think it is away. Even
Extended CCC means that you cannot see the edge, or
yes.
either you can still visualize the edge. So if you think your extension is too much, you should actually not using your single piece, but you have to use your 3 piece so that you can rotate this haptic towards that area.
Away.
So you can it.
Even when you do IA, also you have to avoid that area of extension, right? Because just in case if you take out accidentally aspirate the tag, the capsular tag. So I normally avoid that area. When talking about reason of making side port or main wound first, we talked about this morning, right? Main wound first or side port first? What do you think? For me, it's about having the sharpest blade for the main wound. So when you do side port first, let's say I don't use 15 degree, I use 2.75. So I will not be using that same 2.75 to create my side port first, because it will cause it to get blunt. Then then I use that blunt tip to actually do my main wound. There's no point. So the only reason why you can do using 15 degree first, side port, yes. Then use your main 2.75 for main wound. That's quite okay. I'm not against it. But when you do using the same 2.75, you use side port first. You have to understand that it can easily get blunt. Yeah? And the reason why people want to do side port first is because, as I mentioned earlier, most surgeons would say when they create the main wound, the AC collapses because they press the wound. Because they press the wound, why they press the wound? Because they're anxious. So the last video I showed this morning, it showed that when gush of fluid come out, then it's not possible to proceed with the second part. Eh? So that's my reason. Zairah ada tambah?
I think that will do. Which one is comfort doesn't matter, because when you recognize which one you prefer and comfortable, master that technique. If you're comfortable with main wound, then start with main wound, do it correctly. If not, then you can start with your paracentesis wound first.
Yes, I think there's no right or wrong. But I think if we learn that, there's no wrong of doing the side port first, but by trying and trying to learn how to do the main wound first, then actually you can control your hand throughout the surgery. That's what I told my trainees. So that is actually the fine movement, so that the AC won't collapse, and then you can do your side port. Is this the thinking of that, of all the techniques?
Right. When do we hold Shiga? Who smoke here? Shiga. It's not Shiga. It's a pen holding technique. Shiga smoke. How do you hold smoke? Shiga, when you're smoking. Pen holding technique enough. You can practice using that, but you've been holding pen, right, all the time. But ultimately, I think it comes to when you are actually doing in the real eye or your wet lab. That's it, and you get to know from that. Because I sometimes notice when I do surgeries, my trainees, sometimes they are not looking at microscope. You know what they're looking at? They're looking at my hands or the way I hold hands, because I don't even know how I hold it. It comes naturally to you. You come naturally. Don't worry.
Your hands, they don't water the cornea.
So especially when they're very interested to know how I hold my second port. So I told them I got trigger finger. You can't follow me. The way I hold is different. So it comes naturally to you when you start doing Phaco. Don't worry about that. Nazrah nak jawab tu, is there any precaution doing op on a post Selayang?
This question shouldn't be on the basic Phaco course.
I don't suppose there's any precaution, right? It's all the same. It's about the measurement only. Measurement. Yeah.
It's all about the measurement, pre-op measurement and pre-op, all the information and the biometry is very important.
Yes. All right. Sometimes surgeon struggle to sculpt as the AC felt too deep, like almost more than the tip of Phaco entered the giving pressure. Reduce the water height. Reduce the pressure, the IOP if you use Centurion. And you feel there's a difference. And but very rare that we have this when you have high myopes and you have this. Reduce the water height, reduce the IOP. That's it.
Response during the MSO that this surgeon, they actually, when the AC is too deep, you can either do two things. First, either you can actually just using your second instrument, you just go just beneath the iris to reverse the reverse pupillary block, they say. Or there's one surgeon taught me to actually just do another paracentesis and then put in the iris hook, so that you just want to reverse that the reverse pupillary block, so that you can have a good depth of AC. Is not very deep. But to actually touch your iris few times, that will cause the iris, the pupil dilation will be, you will constricted. So if it's very deep, like in a very high myo or post vitrectomy patient, maybe we can do that another paracentesis with the iris hook. That one was taught by a vitreoretinal surgeon.
All right, when you hydrodelineate after sculpting, you do it in the base, so just above the nucleus. Tak faham. Do it in the base or hydrodelineate. Boleh answer?
Just below the
I think it's just layers maybe.
Layers,
Do you do it at the very the deepest nucleus layer, or is it the epinuclear layer? Dr. Zairah?
layer.
It comes in layers, right? So you
The epinuclear layer. You
hydrodelineate from above. From above. Correct lah. The highest,
you're very near to your PC.
Sure.
I usually go
Yes.
more above the epinucleus layer.
Yes, above. So the fluid can go beyond, behind. Kan? So that's the idea about hydrodelineating.
Sometimes it's become challenging to remove the epinucleus, especially when the thick epinuclear plate remains. What are the tips and tricks to aid easier removal? Oh, besok dah tak payah lah Phacotechnique jawab hari ni.
Just answer.
No, it's actually a good repetition. Repetition is good.
when we do chop, right? And you do with Sinski, what you do, you put your Phaco probe in, you go and put your Sinski behind the epinucleus, lift it up. Or the other way is just to come out from the eye, let the epinucleus float, and shoot with BSS until it's fractured.
I think in Phaco, a job is a bit easy to tackle your epinucleus. The more challenging situation when you do your divide and conquer.
Yes.
Because during your hydrodelineate, you actually sometimes separate your epinucleus more rather than separating your cortex from your anterior capsule. So what I usually did is I will go in a few times to do a BSS irrigation in between the layer so that I can fill up the epinucleus. But still it's difficult when you are too stuck at the superior part.
Yeah. All right, chopping technique, when you say rotate instead of pulling, can you explain in more detail? Rotating your Sinski or you follow the bag, you know, the volume in the bag. You don't pull your Phaco and Sinski in opposite direction. You're actually rotating your left hand or following the curvature of the bag, inside the bag. So when you actually pull towards opposite direction, one Phaco probe on your right, left, since Sinski is on the left, when you pull in opposite direction, it will stretch the bag. That's what I mean. So when you actually rotate the Sinski, it will not stretch anything. You'll just follow the curvature of the bag. So you're safe. And when you pull, there's a difference. When you actually pull, you will not, you know, the fibers, when it opens up, it will not open up to the base. So there's a difference. When you actually dial, you will see your fibers, your lamellar fibers, right, open up to the base. That's how you see TC just now. This it opens up until the base and gets it detached fully. Last question. Any more question? Beginner to avoid pressing too much on posterior lips of the main wound.
You rest your hypotenuse muscles on your forehead and do your handling in the air. So in that case, you are not pressing your posterior lip too much.
This is about anxiety, anxious. When you're, because I've been exposed to trainees, like my Zairah, you notice they're from beginning. But let's say I teach a student from beginning, from not knowing Phaco at all until finish, until they can actually on their own. So you can actually see the difference when they actually, when they first do Phaco surgery, they will rotate the eyeball down or they press the wound. It's because when they feel so anxious, but towards the end, when they become more confident, they can actually do Phaco well. So you notice that one disappear. It's about anxiety, I think. They're pushing the eyeball down, they're pressing the Phaco tip or the blade onto the wound, posterior or anterior.
All beginners are like that. We actually masters day by day. Actually, you have your teacher beside you to tell that you are pressing your posterior lip. You are pressing your posterior lip. And slowly you will actually lift up your fingers for pressing. It's actually your fingers actually pressing. Okay.
We are finished until what time? 4, eh?
We are on 4.
Kalau nak tengok, ada lagi video sebenarnya. Just if you want to fill up time or we can answer questions. Any more questions? I noticed there are a lot more questions when we do online.
Because Malaysians are always shy to ask.
I'm glad anyway to do online. We know what people don't know, so we try to solve it. Just in case if we don't answer your question, you can always you can always SMS us or call us or ask the panel, ask the organizer, right? If our answer didn't answer your questions.
I just want to know, because this is on YouTube live, is it recorded?
Yeah.
Recording, yes. Live YouTube.
Live YouTube and recorded?
Yeah.
Okay, all right. Any more questions?
4 more minutes.
How about the hydrating the wound?
Ada lagi. So,
Yang tanya.
I see some surgeon put in bubble at the end of surgery to stabilize the lens. Is it correct? To stabilize the lens? Is that the surgeon told you to stabilize the lens? Okay.
I thought we put bubble for some decimate there or something.
Yeah. Or when there's at the end of PC run, when we want to know whether we have done
Yes.
vitrectomy, to see whether it's round. It's not to stabilize the lens. The bubble can't do that. Gas maybe, but not bubble. Not recommended. The lens is not, if it's not stable, probably it's due to your wound. Your wound is still leaking. The AC is not stable, so might as well. Or if you need to stitch the wound, you stitch the wound. That's how to stabilize the lens inside the bag. Okay? It's not to give bubble there. Bubble will just disappear in a few hours, right? And the lens will destabilize again. Okay, would you recommend certain lenses and OVD for beginners? I think they're all the same. What do you think? I think they're all the same. Of course, not to use very hard lenses, 3 pieces, like people don't like sensor, I don't know why. But when I was a beginner, I used sensor because we don't have much option at that time. So it's the same, lenses all the same. And we use preloaded, also preloaded, they have problem. So it's very subjective. OVD, you can use any OVD. Just don't use the hypromelos. Use the one with the sodium chromoglycate. Sodium chromoglycate. Sodium base sticker lah. Okay. Don't use hypromelos. That's it. Hyperlucent cataract, better to Diva conquer or Phacotechnique. Phacotechnique lah. Kalau Diva conquer, ECCE.
Better Phacotechnique.
Phacotechnique.
Why better Phacotechnique?
Cataract you Diva conquer enough. Everything. Some suggest that you did a hard percent cataract by using Diva and conquer technique. What they did is actually when they already did a first trench, they actually moving the center of the nucleus sideways. They make the volume of the lens a bit more thinner. So they have more space to rotate, and then they can actually tracking the lens easier than by doing that. So you first trench and then moving sideways. So in the center, the volume is not so much anymore.
Okay, to ensure complete OVD removal, do we go behind the IOL or just stay above the IOL at all times? I was trained to go behind, but that was when I used bimanual IA. It's small, so you can actually flip the IOL and go behind. But for coaxial, you're not advised to because it's big. So what you do, and in fact, OVD nowadays they're developed. It's not like old times OVD when they actually stick behind the IOL and you have to actually go behind and remove it. Nowadays, you don't really see that IOL behaves that way. Normally, we'll complete removal. Yeah.
Maybe you don't need to go behind, you just go to the side. Because we are doing coaxial, we're using coaxial, so you just go to the side and then just gently press the pedal, and it should come out.
And tap the lens to detach the scope.
Wow. Do you suggest us to master? Master means to be expert in CC. You rarely see CC nowadays. You don't see CC in Selayang.
You see more in Ampa.
Yeah, well,
it's not that to master your key.
Not to master. You just
have to know how to do ECCE.
Yes.
That before you dive into Phaco, when you come into a complication, you know how to manage it. Because the management of complicated Phaco is converted to a key manner.
Yes.
That's the purpose of knowing ECCE.
Okay?
Correct.
Exactly.
Kalau nanti dah buat Phaco configuration, ask NO to take over. Kan? Best lah. So you know how to manage the complication. So that's why AK is important.
Do you suggest to load the lens under the microscope, or do you suggest to load the lens somewhere else out of the microscope?
You look the lens.
When you are old, wait until you are old.
Oh,
You need
the lens.
to-
Loading the lens, not in a.
Depends on age. Nazrah.
It depends on age. Yeah, betul. It depends on age. You start wearing
Depends
your
on age.
glasses already, you need your microscope to
Yes.
manually and
I can't download it outside my course because I can't see it. That's the only reason. Okay? It's up to you. It's both safe, provided you can see. Okay?
okay, nowadays beginners or even person already master doing Phaco still have problem that the haptic get caught inside the plunger. So a few companies have come to us and advised us, before you do your implantation, kindly see your haptic and your optic are in the groove under your microscope.
Yeah.
I think that's a good step to do before you inject your lens in, to avoid all these hot haptic inside the cartridge. If we accidentally deliver a preloader outside the lens, can we use any suitable injector? The only things that I know, some hospitals they do have IOL injector that can be used for any type of lens, but not available in all hospitals. Otherwise, you have to extend your wound and inject into the back and switch it up.
Depends on the type of lens, right?
Yes.
So the Monarch system would be good. So you
Yes.
can just insert in the Alcon system and just deliver.
Yeah, yeah, Alcon. And then usually you'll be using the B cartridge. That will be safe, I think. This burger is bigger, but we need to extend the wound a bit.
It's 4:05 already.
So pass the timer. Okay.
Okay, thank you very much for both our panels for a very fruitful session. I think I do learn a lot. I hope the participants learn a lot too, yeah. It's hard for you to, it's hard for us to get you imagine to do the Phaco without a hands-on session. But we still hope that you can still learn a lot and do watch videos a lot, because now there are really a lot of videos available on YouTube. All right. I think I pass it back to Madiha.